This symposium was an invited symposium by the Scientific Program Committee. I think it's an important topic that we spend a lot of time as spine surgeons thinking about the impact of what we do, both with surgery and without surgery, to our elderly patients. Next, we're going to have Wellington Hsu talk about the treatment of osteoporosis in the elderly trauma patient.
Thank you very much, Erica. It's a pleasure to be part of this very important symposium. I'll talk about a very prevalent condition that we'll see in a lot of our trauma patients, whether they're cervical or lumbar in the acute setting. Special thanks to Dr. Jason Savage and Paul Anderson for providing some of the slides in this talk. So this is the kind of case that we have already sort of dealt with this morning. An 80-year-old female who sustained a ground-level fall, has neck pain, type 2 odontoid fracture, and also has osteoporosis. This patient has been on bisphosphonates historically, but currently on a rank L antibody, denosumab, and we'll talk about how that sort of affects her treatment course. We've already heard that the cervical trauma decision tree involves a number of inflection points, whether we treat non-operatively, operatively, whether we go early, late, and then do we go anterior, posterior, and combined, or combine. And a patient's osteoporosis and her bone health will come into factors when we talk about how we do the surgery and whether we do surgery. The risk of osteoarthrosis certainly varies. One-level ACDF is different from a multi-level posterior fusion. I would argue that a multi-level anterior fusion is actually harder to heal than a posterior one. And then finally, if you need to take somebody up to the occiput, upper cervical spine areas, the risk of non-union is even greater in that environment. When we talk about the patients that we operate on, these are often moving targets. There are a number of comorbidities that we need to consider, including kidney dysfunction, where they smoke, diabetes, how old they are, and then finally the spine structure that everybody presents with is going to be different. Is there an associated deformity? Is there chin on chest, multi-level problem, and or corrective osteotomies? But we'll talk about osteoporosis in particular because it's a very prevalent issue. Approximately 14 million individuals in the U.S. are diagnosed with this condition. 30% of postmenopausal women have osteoporosis. 25% over the age of 50 have one or more vertebral body fractures. And this is not a gender-specific disease. 35% of males over age of 75 also qualify or meet that criteria. And then the people we operate on in particular have an even higher incidence of this problem, largely because they're frail and often go undiagnosed. The clinical relevance of osteoporosis needs no introduction. We are concerned about failure of instrumentation. We're concerned about a non-union when somebody has a fracture, since patients with osteoporosis have impaired osteoblastic activity. Sarcopenia is an often associated condition where the individuals have impaired balance, thereby increasing their fracture risk. Patients with osteoporosis have decreased health-related quality of life scores, and recent studies show that this condition leads to increased complications. This recent retrospective review of scoliosis patients in general compared patients with and without osteoporosis and identified this as an independent risk factor for complications, leading to an alarming rate of venous thromboembolism as well as instrumentation failure and the need for revision surgery. Many of these patients don't have the opportunity to treat before we operate on them. However, when they have this condition, it's important to recognize and it can affect the decisions we make. In a more recent consensus conference from the World Federation of Neurosurgical Societies, over 100 papers were reviewed, and a number of salient recommendations are worth mentioning. First, the spine fracture in a postmenopausal woman and or a man over the age of 50 has indication for pharmacological treatment. Second, a drug holiday is necessary after 5 years of bisphosphonate treatment and/or usage. Third, exercise and assistive devices are effective. And then finally, and with some caution, bracing is useful for conservative management. We've already heard how damaging a brace can be for an elderly patient, and so we need to use this judiciously. The endocrine workup, as far as a spine surgeon or knowledge should be, includes a DEXA scan, calcium and vitamin D levels, additional labs looking at other endocrine abnormalities, including prealbumin, hemoglobin 1AC, thyroid function, and testosterone tests, and finally, smoking cessation with a nicotine test when applicable. The DEXA scan remains the gold standard, not because it's the best test for osteoporosis, but largely because of the historical control data that we can place patients in and assess their relative risk. High-risk patients include women over the age of 65, men over the age of 70, history of a fragility fracture, and a FRAX score over 8%. The advantages of this test is that the World Health Organization has a well-established T-score for the definition of osteoporosis. It does predict fracture risk as a whole, not just in the spine. And there is ability to monitor response to treatment with a DEXA scan score. The disadvantage is that as a surgeon, or as a spine surgeon in particular, we want to know what the bone mineral density is in the spine, not necessarily in the hip, the wrist, other areas that have fragility fractures and may not be the perfect test when we assess the bone when we're operating. A more specific test may be a CT scan, in which Hounsfield units that can be calculated with any standard scanner have been correlated with T-scores with a DEXA scan. In a work popularized by Paul Anderson's research group, there are Hounsfield units that we can use in an existing CT scan to look at specifically that question, the bone mineral density in the area that we are concerned about. This was in the lumbar spine, but there's really no reason why we can't use it in the cervical spine as well. Taking that to a next level, a quantitative CT scan, which can be performed with a standard CT scanner with different phantoms, measures volumetric trabecular bone mineral density and is likely more accurate in detecting osteoporosis. This test cannot be directly compared to DEXA scores because we don't have that epidemiological data as of yet. And there's not much data in terms of what this value means in terms of fracture risk and directing treatment. But I think from a surgical standpoint, if we're worried about instrumentation failure, or if we're worried about screw purchase, this type of scan might have the most promise in terms of determining that risk. In a more recent study in postmenopausal women looking at the accuracy or specificity and sensitivity of DEXA scan and quantitative CT, this group concluded that quantitative CT is more accurate in detecting osteoporosis and had a more precise estimation of cancellous bone mineral density than DEXA. No osteoporosis talk would be complete without discussing calcium and vitamin D. Vitamin D deficiency is a very prevalent condition even in the healthy population. And this hit home when I was recently diagnosed with vitamin D deficiency, despite my efforts to play golf whenever I can outside and eat salmon and milk on a regular basis. The people we operate on have an even higher incidence, 30% with a deficient rate, 70% with insufficient rates. And there are sequelae from this. Vitamin D deficiency in particular associated with poor pain and HRQOL scores, as well as increased infection rates. And there's some recent data to show that this deficiency also leads to an increased risk of non-union. This is probably the best study to show that from Ray et al. Looking at a prospective observational study in 133 patients and concluding that vitamin D deficient patients have an increased risk of non-union. And this can likely be applied to patients who have fractures as well, not just those who have surgery. Current calcium supplementation recommendations include 1,200 milligrams daily. And the vitamin D supplementation depends upon whether you have normal vitamin D levels, insufficient, or severely deficient rates. Pharmacologic treatment, a number of options are available to our patients now, including bisphosphonates, SERMs, PTH derivatives, as well as humanized monoclonal antibodies. There are two particular treatments that deserve mention, including teriparatide, where a number of studies have shown now that this drug decreases fracture risk even more compared to bisphosphonates that have been historically used. Data has also indicated that teriparatide improves fusion rates and decreases screw loosening in osteoporotic bone. But there are currently no clinical guidelines simply because the data is not robust enough looking at individuals with either cervical or lumbar surgery, or waiting for a period of time before the patient undergoes surgery. This study, in a prospective non-randomized trial, looked at patients with deformity and concluded that there was a lower rate of proximal junctional failure in the teriparatide group, indicating how robust and powerful this medication can be. Finally, a more recent and a popular drug to be used is referred to as denosumab, which is a RANKL antibody, which is critical for osteoclastic precursors and inhibits bone resorption. This is an advantage for some patients who have kidney dysfunction since it's not cleared by the kidney, but it's important for us to know that there is a rebound phenomenon without other medications. So patients who are on this drug for a while and then suddenly stop it will have a dramatic increase in bone turnover and then are at increased risk for fragility and vertebral fractures thereafter. From a surgical consideration standpoint, there are a couple of things that I think about in an osteoporotic patient, including more likely to go posterior than anterior, additional fixation points, so a longer fusion, a longer construct. And from a biologic standpoint, many times when we have a local autograft, that's enough, even in an osteoporotic patient. But in the setting where you don't need a laminectomy, BMP is certainly an option posteriorly. And if that's not an option with a laminectomy, then I would go to a third-generation synthetic. To conclude, osteoporosis is a prevalent condition in the elderly trauma population. Preoperative optimization is important, but not always possible. And postoperative and or post-treatment endocrinology is really paramount when we evaluate. Thank you.
Real quick, Wellington, who owns the bone at Northwestern? Who treats osteoporosis?
Yeah, we have a bone health clinic staffed by an endocrinologist that not only the spine health or the spine center uses, but also our orthopedic group. That individual is not part of the orthopedic department, it's part of the endocrinology department, but there are standard protocols in place for that type of referral.
Question sort of for the whole group. You brought up the paradigm of the hip fracture, the anticipated mortality in the first year following the event. We understand it as a sentinel event in someone's healthcare. And then there's sort of a parallel potentially to be drawn with the age population and cervical fractures. But there's also a difference. You know, our colleagues have been spending decades trying to figure out how to quickly and effectively fix that fracture. In our hospital, most of them are done under spinal anesthesia. The surgeon is rolling the patient to the PACU by the time we're scrubbing after prepping and draping for a cervical procedure. So the physiologic stress of fixing that hip fracture and what we're talking about doing for cervical spine fracture are widely different. So I'm just sort of interested in what people's thoughts are about how apt is the comparison to the hip fracture patient versus the group that you guys have all been talking about.
Well, I think as one of the few non-ortho surgeons here, I probably am the least able to talk about the comparison with hip fractures, as I've never, fixed a hip. I think that I'm obviously, junior in my practice, but I presented a couple of those cases, especially the third one, because it has made me a lot more conservative in treatment of these fractures in the elderly. Because when I saw that initial C5-6 fish mouth widening, 3-column, multiple posterior spinal fractures, I assumed, I was taught, this is unstable, this needs to be treated. And I thought, for sure nothing good's going to happen. This guy's 96, he's in this collar, he's going to get intubated for some procedure, he's going to have complications as a result of it. And it actually healed very nicely on its own. So I think, personally in my practice, I have led more towards being more conservative. I love the conversation about frailty, but I think one of the other points was, I don't know if you noticed, but the frailty scores were almost exactly the same for all three of my patients. And when I told you the stories of them, there was so much more to their stories. Cardiac disease that has been very stable, even though they're on a blood thinner for the last 5 years, is a different story than the guy who's been hospitalized for 2 months for cardiac failure recently. So even these frailty measures, they're obviously better than just age, but I don't think they're adequately capturing everything about our patients. So, when you do look at the data, though, the mortality rates are really high, whether we operate or not. So, we do need to think about treating these patients if we think that the complications are going to be really bad. And when I do look at the literature, it does push me a little bit more towards thinking, yeah, maybe we should be considering operating on these patients. But then in my own practice, I've sort of had a different experience, and I think every patient's story is more complex even than the most sophisticated frailty index. And I'm sure, all the practicing surgeons here feel that way.
Yeah, I'll chime in. I think, John, your point is very well taken, that these are different interventions, and the implications of both surgical and non-surgical management in the two populations are very different, right? In terms of additional morbidity that it comes along with non-operative management. But I do think that there is a common thread, which is the host. And I think you described it very well, that there's nuance there. But if you look at it at population level, and away from our individual practices, I think there are similarities that we can carry forward. I think we heard a really good summary of the physiologic and bone-specific issues at play, and it's the same in both groups. The fundamental difference as I sit back is that there are just so many more hip fractures every year, right, than there are cervical fractures in this population. There are extrinsic motivations that have also led a lot of centers to come up with really at least consistent hip fracture protocols, right? These are publicly reported outcomes. And so that also has incentivized the treatment of consistent treatment algorithms or protocols, and we don't have that. So I think what we see right now is a lot of fragmentation, right? We all do it a little different. Northeast Ohio, West Virginia, they all have different ways of managing these fractures. I would love, if we have time, if there are any of our colleagues from overseas, from outside of the U.S., who maybe have a little bit more of a systematic way of addressing this population level. I'd love to hear from them, if not right now, during the meeting.
Well, some of the data, though, are actually really encouraging. What was reflected is spine surgeons tend to be a bit more thoughtful and reserved about surgical intervention in this group. 98 to 99% of hip fractures that roll in the door get fixed. It's rare that the circumstance precludes surgery, but yet the data are still the data. 20% of them expire. So, I think we're being thoughtful. It's very nuanced and complicated, but it sounds like at least our instincts are leading us in the right direction. We just need to be more scientific about it, I suppose.
We'll take one more question.
Yeah, thank you. Steve Ludwig from Maryland Shock Trauma. My question is for Tim. I know you focused on a lot of the inappropriate patients that were subsequently transferred down to Metro. We actually have the sort of the reverse problem. With the economics that's going on, with the nursing shortages, with our OR resource issues that are not uncommon for everybody in this room, we're often challenged with that trauma patient, elderly, that's sitting at an outside hospital and is waiting. And they're waiting, and we're trying to get them over, but yet they go from a certain magnitude of trauma and physiologic distress to a much more burdensome level of management. And my question to you is, do you have a protocol where you guys say, we can't, you got to get this patient to another hospital, we can accept them, but there's a liability associated with that, your name is associated with that patient. Do you have any experience with that?
Yeah, I don't. When I'm on call, I'm always shocked at what I get called for, and even more shocked what I don't get called about. But oftentimes I'm on the phone talking to treating physicians, at outside institutions, and I don't. At Metro, at my institution, we tend to find a bed for them, whether it be, I don't tell an outside treating physician to send a patient elsewhere. We just don't send patients out. I think, we're a trauma hospital. We're in the middle of huge, wonderful healthcare institution, and, we're considered a regional center. So I haven't had the issue of sending a patient to another hospital. I think that would involve tremendous liability, like you said. And it might be hospital day 3, okay, but we're going to get that patient to our center and treat them for there. But for this, a bunch of them, we were the 4th hospital that the patient got to at that time.